Wonderful. Well, welcome everyone. I can see that we are coming up to the witching hour of 1 p.m. Central Daylight Time. And I'm watching the little clock go, and there it is, 1 o'clock. Well, welcome to panel 5 of Farm Fest, as we are calling it, sponsored by the University of Wisconsin-Madison School of Pharmacy and the American Institute of the History of Pharmacy. Just a little housekeeping that you've heard probably repetitively over the last couple days, but please turn off your video and your mics so we don't get any feedback and such. And please use the chat for questions, and please feel free to insert them as we go along. We will be answering these questions after the two presentations as a panel. Now, I just wanted to remind you that unfortunately our third speaker, Joanne Collin, has withdrawn her paper on the subject of gender in pharmacy, feminization, and transformation of the Canadian pharmaceutical profession since the 1950s. And I hope to read that sometime in publication. So, on a personal note, I'm glad to be here. Again, my name is Greg Higby. I'm the former executive director of the American Institute of the History of Pharmacy, and I presently serve the Institute as Fischelis Scholar and work in the School of Pharmacy as a senior lecturer and curator. And I have to say, on a personal note, as a pharmacist, I'm very happy that our session that's focusing on pharmacists and pharmacy practice takes place on World Pharmacist Day. That's September 15th. September 25th. Let me get my dates right. On this day in 1912, the International Pharmaceutical Federation was founded. And I think it was in 2009, the idea was, why don't we celebrate this by having a World Pharmacist Day? Now, just to give you a little intro, I was thinking about this session, and it occurred to me that 100 years ago, when my grandfather practiced pharmacy, a patient would enter a drugstore, hand over a prescription, and eventually leave with a small bag containing medicine. And 100 years later, the same exchange takes place millions of times a day across North America. Yet what pharmacists do has changed dramatically and continues to evolve. And it's this evolution and its potential impact on pharmacists' services in the future that is our topic today. And I just want to add that there's a lot of great work that can be done on the history of the pharmacist, especially in the last 50 years. That's why I'm really sad that we don't have Joanne's paper today, because talking about the great gender shift in pharmacy in North America is a fantastic topic that needs further exploration. But instead, we're going to start today with Christian Brown. And let me see if I can find the notes that I made about her so that I give her a proper introduction. There they are. She's a second-year Doctor of Pharmacy candidate in the University of North Carolina School of Pharmacy. Her historical interests include the discovery of pharmaceutical agents and, recently, drug product advertising. She pursues pharmacy history as a hobby to improve her understanding of the trajectory of her future profession. Wow, that's a great reason. And the title of her talk, which she co-authored with Ben Urich, is Capitation for Pharmacy Services, a bold new idea with a 40-year history. Christian, over to you.
Hi, thank you so much for that wonderful introduction, and happy Pharmacist Day. Let me go ahead and share my screen. All right, that looks good. And we will get started. Hopefully this talk adds to the body of knowledge concerning pharmacy practice. So I'm very excited to be here today. The Iowa Pharmacy Capitation Project took place in the United States in the late 1970s and early 80s. It was prompted by increased healthcare spending and introduced a new method of payment for drugs covered in the Iowa Medicaid program using a per patient per month model. And so we will go through a little bit of background just to level set Medicaid and drug spending in the 70s. So Medicaid was established in 1965 by the 19th Amendment to the Social Security Act to offer health insurance to low-income Americans. The federal government sets the rules for the program, including basic services to cover, and the states have flexibility to participate, offer additional services, and decide how to pay for those services. Changes to the basic regulations required a waiver, which was a fairly common process then and now. Drug services were not required under Medicaid, although most states covered medications anyway, Iowa included. Eligibility was also low income based, like I said, and the other qualifying reasons were being elderly, blind, disabled, etc. Children and long-term care were still included in this program. As I mentioned, healthcare spending was an issue. So Medicaid expenditures were increasing exponentially. And even though drug spending during this time remained at about 7%, that exponential growth amounted to more and more money each year. This graph shows the increase of third-party drug payments in the United States from 1960 to 1979. In 2 decades, insurance goes from paying for about 4% of drug costs to about 30%. And note here, the slope steepens around 1965 with the introduction of Medicare and Medicaid. But pharmacists were not happy about insurance setting the price for drugs. In fact, they went to court over it, and the pharmacists lost, but the National Association of Retail Druggists expressed deep resentment over anything seen as interfering with the free market system. Their main target, pre-capitation, was the fee-for-service scheme, which reimbursed acquisition cost and included a dispensing fee. In order to stay in business, pharmacists had to increase volume and dispense more and more drugs in order to make enough money to stay open. So that was the healthcare spending environment circa the start of Medicaid. But why Iowa for a project that could have changed the course of community pharmacy history in America? Since the 1950s and through the 70s, professional pharmacy was changing. Instead of being a purveyor of goods that also supplied drugs, a professional pharmacist was someone who focused on medications. Even the new APHA Code of Ethics from 1969 promoted pharmaceutical patient care. On the Iowa front, the Board of Pharmacy forged partnerships with the Iowa Pharmaceutical Association and the local schools. And in those days, it was fairly progressive to link legislators with practitioners with learners. Not only this, but the IPA also collaborated directly with insurance to base third-party reimbursement on usual and customary rates. This was a system that pharmacists actually wanted that paid the practitioners what they desired in reimbursement. Iowa hosted the first pilot of its kind in the US, and that lasted from the late 1960s until 1979. So continuing this trend of innovation was the Iowa Pharmacy Capitation Project, which ran in 2 short phases from 1976 until 1981, with a few years in between the phases. Each capitated community pharmacy would receive money at the start of the month for the patients on its roster. By decreasing drug expenses, pharmacists would then increase their profit. And this was a radical change for the fee-for-service model, because instead of promoting volume, capitation rewards cost containment by encouraging pharmacists to take an active role in optimizing therapy to lower drug utilization. Just a note on sources, this project was incredibly well documented, and the author of a comprehensive report to the Iowa Pharmaceutical Association sent us all of his files. It was 1.5 banker boxes full of paper, and it included letters between project stakeholders and other reports that recorded personal opinions of the people who were in this project. We supplemented that information with 3 oral histories, one from one of the project investigators, one from the executive director of the Iowa Pharmaceutical Association, and then one from a capitated pharmacist. So phase 1 ran from mid-1976 to mid-1978, and it involved 2 capitation counties and 2 controls. These were rural counties in Iowa that only contained independent community pharmacy, not chains. Because in the 70s, more than 85% of community pharmacies in America were independent. So the patients were required to stick with one pharmacy for the whole month. Medicaid, serviced through Blue Cross Blue Shield, paid each of the pharmacies 90% of their predetermined capitation rate, and they kept 10% in an escrow account to make overflow payments with the intention of sharing the savings between the state and the participating pharmacies. Blue Cross Blue Shield closely managed this project and scheduled educational meetings for the groups of the pharmacists and the physicians to teach them about generic prescribing and drug product selection, which became legal in Iowa the very same day that the project started. Data analysis fell to a research team based at the University of Iowa who compared capitation data with generic substitution and cost data from the years prior to the intervention. The goal was to determine if capitation caused pharmacists to better serve their patients, better conduct business, and better contain costs. And it actually worked. The pharmacists significantly increased generic substitution, and drug spending went way down. Without a dispensing fee, day supply also increased. And when appropriate, the pharmacists swapped prescription drugs for OTC and covered the less expensive over-the-counter products under their capitation rate, so their patients would still have a zero copay. And they did all of this without cheapening the quality of care to their patients. There were, however, a few challenges with the implementation. It was really hard to get patients to subscribe to one pharmacy. So facilitating the lock-in took multiple attempts by BCBS before they just assigned non-responders to a pharmacy. And they said, go here, get your medicine. Educating the capitated pharmacists and physicians was also a challenge. As I mentioned, capitation completely changed the focus on healthcare reimbursement, and it took some getting used to. It also took a little bit of convincing to substitute for generic products in this pre-Hatch-Waxman era. So after all these early successes, the project team set out to disseminate their results and secure funding for expansion. But not everything went according to plan during these in-between years. So one good thing that happened was that generic substitution was on the rise. A not so good thing for the project was that the Iowa Department of Social Services commissioner resigned, and the project team had to form a new relationship with the incoming commissioner. And the jury was out for a while on whether or not the new commissioner actually supported the capitation project. A year after that, in July of 1980, the 3-year contract for Blue Cross Blue Shield ran out, and Systems Development Corporation took over as the Medicaid servicer. And they were not on board with capitation, and they charged the state of Iowa separately for its capitation claims, and that causes problems later on. Also, Blue Cross Blue Shield ran the project. So planning, executing, and analyzing for the expanded phase fell to the University of Iowa research team, which was also in flux with their primary investigators moving into different steps in their careers. Yet another change that occurred was with the professional organization. So new leadership came in during this time, and the groups that were opposed to capitation took advantage of this transition period to try and bring down the project. And this included Pfizer, Eli Lilly, the National Association for Retail Druggists, a splinter group of concerned Iowa pharmacists, and a member of the Iowa State Senate. So despite all of this, the pilot project had still met DSS stipulations for expansion. So the university research team was able to secure funding for capitation to cover 1/3 of the state counties, with another third serving as a control. So the expanded phase ran from April to December of 1981. And this picture in the corner shows the educational pamphlets that were mailed out to the capitated pharmacists to teach them how to work in a capitated system. The project was supposed to start earlier, but the waivers that I mentioned took a long time to prepare, and there was a big mix-up with whether or not the waivers were actually required, and they were, and it took forever. But most of the goals for the expanded phase were the same as in the pilot, with a few changes in the logistics. The main things were increased escrow withholding. Now, the pharmacists were paid 80% of their capitation rate, and they held 20% in escrow to cover greater supplemental costs. Another big change that happened was education delivery. In the rural pilot project, it was really easy to go around and talk to the pharmacist. But with urban areas added to the expanded phase and so many more pharmacies to coordinate, education was restricted to those packets and a couple of regional meetings that were sparsely attended. So whether or not the educational efforts were sufficient was a matter of debate. But the outcomes show that although drug costs decreased a little bit, administrative costs increased due to unexpected requirements in the claims reporting and because of profiteering with the new Medicaid servicer charging the claims separately. So none of the cost-saving measures panned out for the capitated counties as a whole, but surprisingly, Polk County, which contains Iowa's largest city, Des Moines, had statistically significant cost savings, and no one could figure out why. Like, they do not know. But come December of 1981, the DSS terminated the project early. Ostensibly, this was because the commissioner thought that the university team had enough data to make a decision on capitation. But there was also pressure from the Senate to balance the Medicaid budget that was severely underfunded at the time. And those high administration costs really did them in. Not to mention that, but the delays with that waiver process eroded the confidence of the state pharmacists in the study group. And they did not significantly alter their dispensing behaviors. So that wasn't great. But the real trouble came from the pharmaceutical industry. Big Pharma was already mad about generic substitution prior to capitation. So this project was insult to injury. Eli Lilly ran a couple of columns in trade journals, as you'll see on the next slide, but Pfizer did so much more. Their lobbyists got in with the Iowa Senate Majority Leader, who asked his pharmacy friends about capitation, and his friends, who were not capitated, got the wrong impression, and then the senator started pressuring DSS to shut down the program. On a related front, NARD, that didn't like anything construed as anti-competition, convinced an IPA past president to found a splinter group of concerned Iowa pharmacists to stir up the local pharmacists against the program. And then Pfizer funded the whole slanderous thing, and the national news caught on to pharmacy being divided against itself. So this is the heading for the two-page spread that Eli Lilly published in the Carolina Journal of Pharmacy and other trade journals for several months in 1981. There was a disclaimer located at the bottom of the page that said that the views presented here were not necessarily representative of Eli Lilly, but the column that they put out before this one was about generic substitution. So I'm pretty sure that this actually represented their views. This headline is a personal favorite of Dr. Urich's. It is a 7-page pseudo-transcript from a roundtable discussion funded by Pfizer, hosted by NARD, held at a fancy resort in Arizona. And you can see here the kind of yellow journalism employed by Pfizer and the Splinter Group. It says, there's a newer and bigger cloud looming over the Medicaid horizon that promises to overshadow the fixed fee problems currently plaguing independent retail pharmacy. Its name is capitation. And in the eyes of some Iowa pharmacists who have felt the brunt of this so-called experiment, to determine capitation's feasibility in the Medicaid system, it could spell decapitation for retail pharmacy as we know the profession today. Wow. So that was the Iowa Pharmacy Capitation Project. The intentions were good, the environment was bad, and the opposition was ugly. One of the primary investigators said that this project revealed less about capitation and more about the challenges delivering social science experiments. He also said that it was impossible to determine whether the project succeeded or failed because of all the confounding. Interestingly enough, groups that once opposed capitation are now in favor of testing alternative payment models, but these models are pretty popular right now, so that's not entirely surprising. Other aspects of the project that translate today would be mistrust in the system. I don't think I need to explain that one, but Americans could be quite skeptical of government involvement in anything. But leaving that away, there was also the challenge of creating lasting change. As it turns out, altering behavior is hard. Like, you could not pay these pharmacists to operate differently. Additionally, what constitutes the delivery of good healthcare? Surely the pharmacist's role in healthcare continues to be in flux, but alternative payment models and value-based delivery systems are also redefining the concept of good. Not to mention that even in the 80s, overutilization of medical services was a problem. So it sounds like not much has changed since this project. But despite all of these challenges, the External Evaluation Committee that was commissioned by Iowa DSS remarked at the time that the project would be a most significant and important milestone in the history of public policy development for prescription services payment. Maybe, but only if people know the full story and allow it to change their practices. Thank you very much, and we'll take questions at the end.
All right. Well, thank you, Christian, very much. And I encourage people to please put some questions. Well, I see a couple of questions going in the chat. That's wonderful. And we will come back to those at the end of Michael's presentation. That's great. Again, our next speaker is Michael Oldani. And again, I will find I want to get everything correct here. There we are. He's a professor at the Concordia University, Wisconsin School of Pharmacy, where he's the director of interprofessional practice and education. Speaking of education, he received his PhD in medical anthropology from Princeton, and he's found himself a home in the world of pharmacy, where we're very accepting of people from all kinds of intellectual backgrounds. And he's also an adjunct professor at Western University. So let's see, the title of his talk, which I think is a great one, is The Impossibleness of Radical Deprescribing. Can Pharmacy Take Back the Script? Michael Oldani, take it over.
Thank you, Greg. And you can hear me fine? Just want to make sure. Thanks for letting me be part of this great conference and to share some of these ideas in an early draft of a paper. I really appreciate it. I'm going to be reading a paper and kind of pushing some slides through, and it's really, the reading is to keep me on track. So deprescribing is a set of clinical practices that have established a foothold in pharmacy over the last decade. Geriatric pharmacy is an exemplar where pharmacists collaborate with interprofessional teams, work to deprescribe by either tapering down or discontinuing unnecessary meds. Classes of medications like proton pump inhibitors, benzodiazepines, and opioids are the kinds of meds pharmacists are deprescribing. This makes sense considering the well-established data on polypharmacy and protocols such as the Beers criteria, based on data showing increased falls risk for seniors taking the fifth medication, regardless of class or compound, that this will increase falls risks. Sus, a geriatric pharmacist, and I, medical anthropologist, focused on benzodiazepines specifically in our own work because of his concern at a geriatric clinic in Milwaukee, where benzos were often scheduled for patients over 70. And together we were working on an in-home interprofessional team visiting seniors in Sheboygan County, where benzos were lurking in medicine cabinets, bedside tables, and in general as nervous pills for isolated seniors. Deprescribing in both contexts were driven by the observations and protocols of a practicing pharmacist and another pharmacist with home care experience who was also on the team. And this interprofessional team consisted of nurses, an OT, PT, and myself, a clinical ethnographer. Sus, before leaving his practice in academia, he was recruited by Pfizer, maybe more on that during Q&A, had devised an interprofessional framework for deprescribing through the electronic medical record. Similar to the VA system, the provider prescriber would have to scroll down and interact with the record and make note of the pharmacist's deprescribing recommendations before being able to move on to the next window or screen within the EMR. The system worked well, and that particular clinic can track the medications deprescribed over time. Benzos PPIs, and CNS active drugs in general. In my own ethnographic work, I have seen solo practice psychiatrists, solo prescribers, deprescribe and or taper down and off medications within the mental health domain. Diane is a paradigmatic example where a psychiatrist, Dr. W, during MedCheck clinical appointments, was able to taper Diane off her polypharmaceutical cocktail of lithium, Depakote, and risperidol to a single SSRI antidepressant, escitalopram. This took time, months actually, of MedChecking, use of the historical EMR, and negotiation or drug talk with the patient. In particular, negotiation in the form of undiagnosing Diane from a bipolar 1 disorder to depression with anxiety features. In particular, this was the hardest part, as described by Dr. W, getting Diane to change her sense of self, what the literature calls her illness identity. Some psychiatrists have worked, that I have worked with ethnographically over the last decade, will use med checks to work with patients who they feel may have had more situational symptoms and describe them off of all medications. Dr. V in 2010 shared a case where a young woman in her mid-20s came to him with panic attacks taking paroxetine and alprazolam. And at the first med check, told him she was doing fine on meds, but was still quite nervous about her upcoming wedding. Over the next 6 months during med checks, they worked through the wedding anxiety together. They slowly uncovered her resistance to the marriage, her calling off the wedding, and their deprescribing together to remove the benzo completely and then tapering down the paroxetine until she left his practice on no medication. There also is what we might call, that we can call a grassroots deprescribing movement underway. There is a RX memoir literature in Sharp and Bell Barn are examples where former patients prescribed SSRIs for often a decade or more, deprescribed, for often a decade or more, described through their own narratives, as well as the cases of others, the long process of deprescribing antidepressants out of their lives. These works capture the struggles and ambivalence people feel, as well as realizations about how their lives were impacted by psychotropics. More recently, those who seek and struggle to find providers to help them taper off of these compounds have found actual withdrawal counseling online at places like the Withdrawal Project, where after signing a waiver, one can enter an online community to find examples, case studies, protocols, and advice on tapering down and off of SSRIs. Finally, I want to share an emergent business platform for deprescribing called Taper MD, which was founded by David Healy et al. Of RISK, and that's RXISK. Some of you may be familiar with that, who has created a way to quantify side effects in drug interactions and efficacy/synergies of medications into burdens, anticholinergic burden, falls risk burdens, opioid burdens, and so on. So when you use this software and plug in the drugs, a provider prescriber could then see the burden, discuss with the tapering team and the patient, etc. An ethnographic focus group conducted at our school showed the taper team that pharmacists could, perhaps should be, the main driver of this process and the ones to insert it into the EMR. Parts of Taper MD, and we can see some of the resources they have here, like the PIMS resource, are open source and free. Others require payment. Despite these social pharmaceutical movements, deprescribing remains burdened itself with a lot of different kinds of inertia. Patients often resist or become confused when asked to deprescribe medications. Some drug sets have been prescribed for decades. In psychiatry, an illness identity is at stake. Family members may balk at deprescribing, tapering, and changing medications. Case managers and social workers are often reluctant to quote unquote rock the boat. For example, in specialty court domains such as drug treatment and mental health court, getting to appointments, meeting with more specialists, and questioning med sets in general is almost taboo. It's not uncommon to have individuals in drug treatment court being prescribed stimulants and benzos, for example, with no question about deprescribing those medications. We also have provider prescribers who during training are normally not enculturated into deprescribing practices, geriatrics perhaps being an exception. Rather, they are anxiously and excitedly waiting to enter the prescription network or machine, a ritualized culture of prescribing. And what does this machine training consist of? Well, it involves three things normally: pharmacology classes, learning, modeling, and or coaching from other prescribers, and what I might describe as entering the structural imaginary that took symbolic and practical hold on medicine during the 1990s. Kathy, and that's the name of Kathy in this fictional story, was and remains a paradigmatic case of the 1990s for pharma. Big Pharma winked at us with this graphic ad, where pharma and advertiser marketers exploited every kind of cultural script to advance the prescription machine, at the core being consumer demand and empowerment. Follow the graphic script: family life, gender, web-based self-diagnosis and branding. See the Zoloft poster? Of provider prescribers, synergy with drug reps who are a bit invisible in this ad, but nonetheless are always lurking. The return of normality, family, mothering, gender, pharmaceutical harmony. In short, pharma helped create both the structure to generate prescriptions and the cultural imaginary to fuel consumer demand and ideas of pharmaceutical efficacy. The Me Too era was upon us by the late 1990s, and we are left today with a marketplace of overprescribing, pharmaceuticalization, e.g., a drug-first mentality for all chronic disorders, and generic saturation, meaning the pharmaceutical marketing machine has moved on to other compounds and classes of medications, namely biologics, monoclonal antibodies, etc. More on that shortly. Between 2000 and 2012, the proportion of adults in the US who were taking 5 or more medications nearly doubles from 8.2 to 15%. In 2019, 42% of adults over the age of 65 took 5 or more medications, recalls the Beers list. It's estimated that 1 in 5 older Americans, around 10 million people, experienced an adverse drug event in 2018. Over 250,000 were hospitalized due to medication reaction. Over the next decade, estimates show that we can expect 4.6 million hospitalizations of seniors, 74 million outpatient visits, and nearly 150,000 premature deaths due to medication. The post-1990s world of pharmaceuticalization also rebooted the pharmacy profession, both in terms of expertise, the drive towards PharmD-only degree-granting programs, and the proliferation of pharmacy schools, and I'm quite thankful of that. This was based in part on the retail prescription machine, and filling those scripts led Walgreens executives to proclaim in the early 2000s that they could hire every new pharmacist produced for the next decade. This proclamation seemed prophetic up until 3 or 4 years ago, when demographics and the lack of provider status began to significantly impact PharmD program enrollment, as prescriber programs like PA and nurse practitioner, physician assistant and nurse practitioner, continue to expand and grow. The challenges ahead for pharmacy is to begin to write a new social history of the profession. This social history can and should be built around new pharmacy practices, specifically scope of practice and or collaborative practice agreements that fully incorporate deprescribing as a pharmacy-centric collaborative practice, where providers look to and advocate for pharmacy's scope of practice to carry out deprescribing initiatives. The majority of providers are willing to hand off deprescribing tapering duties to pharmacists. This already occurs in the aforementioned geriatric. Deprescribing also can occur in ambulatory care settings where collaborative practice agreements are in place, in particular for diabetes medication management. It occurs at the VA, in particular in mental health services where interprofessional teams work to deprescribe psychotropic medication. A recently completed clinical ethnographic project we did at Concordia demonstrated how other interprofessional sites where medication saturation is high, but pharmacy and or provider participation was historically low or non-existent, such as drug treatment court or mental health court, is another ideal site for pharmacy to intervene, sit at the table, and engage in deprescribing, and ideally with other providers. These kinds of deprescribing practices will provide a new niche for pharmacists and the profession moving forward, and perhaps a new mindset for practicing pharmacists. Where can I deprescribe? Could this be the call of a new generation? However, I want to suggest that pharmacy as a profession should also engage with the deprescribing machine at a more meta level, that is conceptually, and also at a structural level, at the nexus of the marketplace, marketing, medicine, and society. If we think about the modern blockbuster era of pharmaceuticals from roughly 1990 to 2020, a 3-decade increase in prescribing, marketing, and consumer demand for pharmaceuticals to where we are fully saturated today, both in imaginary and concrete ways, with generics and emergent blockbuster biologics. We can draw parallels to the 1880 to 1910 period, where patent medicines had completely saturated and infiltrated U.S. homes, pharmacies, doctors' offices, and medicine bags, and even the pages of medical journals and 10-cent paperbacks through advertising. It was pharmacists who joined concerned medical doctors in advocating for, if we can rename it for the sake of argument, the deprescribing of patent medications by doctors. This proved a difficult challenge because as more scientifically proven material medica became available through a doctor's prescription, pharmacists were still generating revenue through the sales of patent medication at their stores. Nevertheless, led by perceptive physicians and pharmacists, a denunciation of nostrums continued, and advancement of synthetics, in particular from Germany, continued because the formulas were known. By 1893, Young of Toadstool Millionaires, kind of a well-known book on patent medicine history, describes a valiant corps of pharmacists who continued the attacks on patent medicine while advocating for prescriptions of regular drugs. These pharmacists were joined by chemists also fighting fraud in food, as well as lay critics. What they were able to do is decouple the money marketing advertising machine of patent medicines, and one by one, major journals, magazines, and newspapers began to pull back from taking patent medicine ads and money. The question of transparency emerged. What was inside of these nostrums? And journals were able to decode their properties through collaboration with pharmaceutical labs. Collier's Journal and the journalist Samuel Hopkins Adams, some of you may be familiar with this, in a series of 10 articles to Great American Fraud, as well as editorials between 2005 and 1907, mentioned 264 medicines, doctors, and firms involved in fraudulent activities. In 1906, the Pure Food and Drugs Act was finally passed, known as Dr. Wiley's Law. Patent medicines were finally being prescribed. And in closing, transparency was a key factor in this necessary phase of deprescribing. And today, pharmacists who want to engage in deprescribing at these interconnected levels, from patients to patented pharmaceuticals, should come to understand how the pharmaceutical industry continues to induce prescribers to write new generations of medications, such as complex biologics with a range of serious side effects. If we examine the exchange of money between pharma and prescribers from 2018, we can see the top 10 expenditures to prescribers were for biologics. And this is from the Sunshine Act via ProPublica. Humira, soon to pass Lipitor, that 1990s drug, as the all-time leaders in total global sales for the life of a branded prescription drug, is not far off the top 10 at $12.5 million paid out to doctors in the form of speaking fees, lunches, and free coffee. We can see too how much prescribers are being paid to educate other prescribers about a drug such as Humira. And high prescribing begets high prescribing. This is an industry truism. The challenge forward for pharmacists, if they are to engage in radical deprescribing, is not only continue the kind of clinical work that makes patients healthier and safer on less medication, but fundamentally work as a profession to decouple money marketing advertising from the prescription machine. Because prescribers up to this point continue to ebb and flow with the hype and the enticements of the marketplace, similar to the patent med era. Pharmacists as a profession are in a unique position to rewrite the script by expanding their scope of practice through resistance to the machine as deprescribing, and in doing so might change the way prescribers actually care for patients and in the long run think about their daily prescribing. Forgot this one last slide. Thank you very much.
All right. Thank you, Michael. I guess I'm, yeah, there I am. It helps if I see myself. We've got many questions here, and luckily we have a nice amount of time. And I think what I'll do here is just go through the questions pretty much in the order I received them. One of them comes from the United Kingdom from our colleague Stuart Anderson, who has a question for Christian. And please, if Michael and Christian can put your video cameras on as well, that's nice to see people when they talk. The question that Stuart asks is, there we are, for Christian. Capitation was rejected by British pharmacists when national insurance was negotiated in 1910. Did Iowa pharmacists consider the experience of similar schemes operating overseas when the Iowa scheme was proposed?
That's a great question. Thank you for asking that. From the sources that I've seen, I actually didn't see very much about looking into overseas models when they were developing their capitation scheme. They connected it to the health maintenance organization concept that was gaining steam during this time, and they connected it to capitation for medical services. And that was really what they used to say, hey, this has been done before, let's try it. They did make some overseas presentations during the in-between years, mostly in France. But unfortunately, I didn't see anything when they were looking at the British model and a universal health insurance as saying that capitation did or did not work.
Christian, I have a kind of sort of not exactly a follow-up question, but it's related. It's from Richard Del Rio, who asks, what sources do you use to tell the story of those in-between years? Also, was Iowa alone in this capitation experiment, and how widespread was the thinking behind capitation?
All right. Let me scroll back up in the chat so I can see it. Okay. The sources, okay, so the banker box full of papers that I mentioned came from Dr. Ronald Hatzel, who wrote the very extensive report that was commissioned by the Iowa Pharmaceutical Association. In that box of papers, his report came out in 1983, and so he had a great number of documents that described how people felt in the in-between years. So he had some of the letters that were sent between the IPA executive director, and he sent letters to Pfizer, he sent letters to NARD, and he sent letters to local pharmacists, I believe. And then he also had some letters in there from local pharmacists to the Concerned Iowa Pharmacist Group. And there was also a report in there. There was a report written by two newspaper journalists who did over 60 interviews to collect information about how people felt about the project. One of the goals for that report was not to determine whether or not their feelings were consistent with what really happened. It was just to gather how people felt about it. And specifically that report is where I learned that the DSS commissioner might not have been on board. Somebody else wrote all of his letters to the project team, and then it has interviews with the commissioner, with members of the primary investigation team and with the senator. And between all of their opinions, he probably wasn't in favor of capitation. Last question on this. How widespread was the thinking behind capitation? Before the Iowa capitation project, so during the pilot period, it was really just the state of Iowa. So the pharmacist that started the Concerned Iowa Pharmacist group, he was on the board of trustees for the Iowa Pharmaceutical Association when they approved the capitation pilot. And he said, yes, do it. It was a unanimous approval. After things looked like they were going to go national, if the capitation project worked in Iowa, they were considering rolling it out on a much larger scale. That's where he got scared. And then also with the Eli Lilly journal page, that was published in a couple of different trade journals. I showed you the picture from the Carolina Journal of Pharmacy, but there were also ones elsewhere. And then NARD, the National Association of Retail Druggists, they were a national organization, and their trade journal had a couple of rebukes for capitation, and the writings put out by their director also went national.
Well, that leads me to a question that Bill Zellmer put forward about whether there was an effort to build patient support for the project, and if not, in retrospect, might that have been an important oversight in the design?
Also a great question. I do think it was important oversight in the project design. There is not any data in the sources that I've seen concerning how patients felt about it directly. There are a couple of pharmacist interviews that said if one or two patients gave them grief about the lock-in process or about what would happen, like if they left the county. Those were far and few between, but some of the opposition from the stakeholders at the National Association of Retail Druggists and a couple other ones, they were concerned about how the lock-in would restrict patient access, and they were also concerned about the quality of generics that were being substituted and whether or not patient care would suffer. So that was a big part of that roundtable discussion that NARD and Pfizer put on. But as far as the University of Iowa team is concerned, I didn't see much about patient buy-in. So I think that was an oversight. That is a fire alarm. I am currently sitting at school, so I'm going to take my laptop and go outside, and I'll just mute and stop my video for a little bit.
All right. Good luck, Christian. I hope you survive this fire drill. All right. Well, we've got plenty of questions for Michael in the interim, so don't feel bad about it if you get hustled out.
Good. The alarm actually turned off, so it might be fine.
Might be just a test. Might be just a test. All right. Well, speaking of Michael, I've got a couple questions for him. I might as well get started there. Here's one from Gail Scott. You position pharmacists as uniquely likely to be able to resist the machine of pharma marketing. But if PharmDs achieve provider status, they'll be targeted by pharma in a way they are not now. Don't you think it'll be more difficult to insulate pharmacists from the enticements then?
That's a great question. Well, if history shows there's always a certain percentage of providers, those with provider status, that enter into, we call them the medical anthropology world, the gift exchange network. I mean, that's the key sort of area where pharma is very good at very low level exchanges, and then of course very high level exchanges, paying for clinical trials, so on and so forth. However, one thing I think pharmacy as a profession, having been at the school for 5 years, it's really the approach to evidence-based medicine that pharmacy takes when it comes to prescribing. And it's not that providers don't get that, but they just don't get the same degree or depth. And I don't think they're trained in quite the same way to balance side effects, drug interactions, and actually cost effectiveness in the same way. For example, in our PA program, which is a 2-year program, PAs are literally having one course, one semester on pharmacology, and then they're let loose onto the world. So we've really tried to train them to partner with pharmacists right now in school. And, we do that through the interprofessional program. So it's a great question. I love bringing my formulary pharmacist in to one of my classes, and there's one in particular, I will not name her, who runs a formulary up north, and she says it's her great joy in life to make drug reps cry. Now, that's a little harsh, but the way she does that is by making them engage in the evidence-based literature. And the industry really is not that interested. They're interested in talking about Kathy, that cartoon I had up. So I think it's a great question, and I think it will be something to definitely watch. And then the question will be, and I'll just finish here, will pharmacists enter into that kind of sunshine data zone? PAs and nurse practitioners, the dollars given to them right now by pharma are not being tracked quite yet. Some states are adding them. So you can't put in, your average PA and find out how much money they've taken from pharma. You can for a doctor.
Yeah. What about the pharmacy professional organization in this revolution of deprescribing? And we know how much they rely on income as far as advertising and so forth.
Yeah, that's a great question, Greg. And I'm going to say right off the bat, I haven't done enough research in that area. I think it's something I probably should look at, considering this sort of position I'm taking. I've been looking at it more kind of on the day-to-day on the ground, but the professional organizations, that would be a great start. And then you had said for deprescribing or you're thinking more about pharmaceutical influence. Mm-hmm. Yeah. To be continued for me on that front. If others have something to add, that would be great.
Also, I got Michael, the question here from Richard Del Rio. Can you speak more on the conflicts and tensions that usually accompany the life of a person with a, quote, disease identity?
Sure. Some of that literature I pointed out, I think, is really an important literature. If you talk with really anyone, but especially young people in the mental health area, in the mental health field, you'll encounter every sort of example you can think of where having an illness imploded in someone's life and a diagnosis was fundamental to their surviving the illness, that getting the diagnosis was that important. And taking on that identity was fundamental to who they are moving forward, and they're quite happy with that. But of course, I think pharmacists should be prepared for the spectrum, which also includes a lot of people who never quite understood that identity or resisted it. And some of the literature I cited is really interesting to read. So for example, if you take adolescents who were prescribed psychotropics and in particular SSRIs, there's a chapter in Sharp's book about sexual side effects, which provider prescribers often downplay because pharma has downplayed them, or did when the drugs were branded. And when they came off the medications, they realized for a decade of their life, this idea of them being asexual was because they were inhibited sexually through the side effects of the medication. So there's complex, I think, interesting areas for pharmacists to be attuned into when it comes to the illness identity work. And it's not just mental health. Obviously, people work with type 2 diabetics, and people start identifying as pre-diabetic, and so on and so forth. There's nothing wrong with that. I always come, of course, from the pharmaceutical industry perspective, and they've advanced a lot of these ideas of pre-hypertensive, pre-diabetic, and it's kind of a grooming of potential patienthood. It's a great question. I think it's a great area of research for pharmacy.
Clark Ridgway has a question for Christian. The majority of nursing home long-term care patients are Medicaid recipients. Were nursing home patients included in the capitation project?
They most certainly were included. So the nursing home, actually deprescribing, was one of the most relevant areas for cost saving in the pilot project. And nursing home residents in those few counties, they went from maybe 4 or 5 prescriptions each to 3 or 4. And with the volume of patients, that saved a significant amount of money. So that contributed to the 16% savings. For the expanded project, nursing homes were still included. And there was a vestige of data that said that it worked, but the corresponding data really didn't match up. And so the investigators didn't think that that was statistically significant, but they most certainly were included, and there was an effect in the pilot phase.
Great. Paul Ranelli here puts up kind of a toss-up question, which may get reactions from either our speakers or from in the chat. He says, in the United States movement toward a single payer program, it's molasses slow, as he calls it, but we're getting there. What's pharmacy's position on this? Will the profession in the U.S. be a winner or loser under a single payer environment? I know that's a kind of a $10 question, but I'll throw it out there, and if anyone has any comment.
Christian, why don't you, as a future pharmacist, take a stab at that?
I am a future pharmacist. In the interest of full disclosure, the second-year students at the Madison School of Pharmacy are currently taking a U.S. healthcare system class. So my opinions on this topic are 5 weeks old. But I agree that we are going quite slowly. I think, so one professor actually gave us a great quote. He said, if pharmacists are not at the table, they're on the menu. And so I believe that wherever pharmacy decides, and so we think like provider status is going to fix this, but it depends on the payment model. It's a whole thing. I am not well steeped enough to answer this question. I think it's a great question, but there's a lot behind the scenes that I just do not know about yet.
I would only add, from an interprofessional point of view, and I kind of swim in those waters now, you know, Canada and the VA, there's always a joke at the large interprofessional meetings that interprofessionalism is done really well in Canada and the VA. And from a single payer point of view, in some ways, you know, the VA gets a bad rap, in the press often, but from an interprofessional point of view, like our pharmacist that works on the interprofessional mental health team, in that VA system where they don't have the same kind of payment model, she loves her work, and the providers lean on her to taper up and down to make certain kinds of medical and medicine decisions that I think her job seems really valuable and rewarding. And that's why we encourage her to come work on that mental health court team, because of her expertise. But the single payer system may be looking to Canada for some of the literature there. And pharmacy has advanced provider status in a lot of provinces in Canada. Compared to the US, might be a good place to start.
I have my own question, which is inspired, Michael, from your mention of electronic medical records. Here we are in Madison, which is the home of Epic. And I just wondered, you mentioned, the tools that some of these systems have that might help in deep prescribing. Any more comment about that?
Yeah, my observations in the clinic came from 2 sites. One, the pharmacist I worked with, where, I feel like the electronic medical record, and I haven't done a lot of ethnography on it, but what I've seen, for example, psychiatrists that can scroll back and forth with a client in real time and ask really important questions about medications where they might find discrepancies, because they can crank back in real time while they're talking to a client during med checks. That was really important. And the other thing I noted about being able to have a provider read the entry from the pharmacist before they can go on. I know that's part of the VA system as well, as I understand it. Some of the problems we've seen with deprescribing is when we If we don't have access to the medical record, like we have a project in Sheboygan where we visit seniors, we make recommendations and we give them a piece of paper, which you can imagine is very problematic. And we say, bring that paper to your provider. And if you can't sync with the record, it's almost a foregone conclusion that's, nothing's going to happen. But I'd be interested if other pharmacists, I think the EMR is a blessing in a lot of ways, but also present some barriers when it comes to getting the team kind of being responsive to what's going on. I don't know if people have worked with interprofessional teams where they're asking the team to come up with one note for the EMR, and that's going to be an interesting way moving forward, how that works. It's a great thought question.
Great. Well, I see we have a little. We can go a little bit longer if we'd like. Melissa, I see your image came up. Did you want to make a comment or two? I think I can.
Oh,
I think you're up.
I'm Melissa Muir-Corrigan, and I'm a board member for the AIHP. We're doing this a little differently, navigating in a virtual environment, but I think we're making it work. Today, we're celebrating World Pharmacist Day, and we appreciate a session such as this one to really cause us to pause and think. And I just want to highlight kind of the 3 pillars that we're working on at AIHP. We're working on collections, we're working on programming, such as this one that we're having today, and then we're also working on publications. So if these seem interesting to you, we hope that you'll give a look at AIHP and consider membership and getting more involved. And finally, like Greg, I was bummed that we weren't able to have the Women in Pharmacy presentation today, and look forward to when that comes out. And just wanted to share that in a few weeks, we'll celebrate Women Pharmacist Day on October 12th. And I'm working with AIHP. We've got something special in the works with the fabulous Meta Lou Henderson. So stay tuned. You'll hear more about it, but we've got something really fun planned. So appreciate, Greg, the opportunity to share a few remarks, and looking forward to later today and the next few days. There's some really exciting programs, and I want to give a shout out to my other AIHP board members that are on the call today.
Thanks, Melissa.
Jada.
And there we go. Perfect. Okay. Well, I see it's the witching hour now, and I appreciate everyone's participation. It's been great. Our next session will be the AIHP Early Career Roundtable conversation, and that starts at 2:30. And there's a link for that on the festival program page, and everyone's invited. Even us old guys are invited, I guess. So take care, and I really appreciate your participation in this program, especially go celebrate World Pharmacist Day in your own way. I'm going to have a cold drink, I think. So take care, and we'll see you all later. Thanks for coming.
Thank you.
I should have followed up on that. Christian and Michael, you did a great job, and I really appreciate your participation. And congratulations to Ben for the new addition to his family on Wednesday night. So that's a new historian of pharmacy is on the way. Thanks, everyone. Bye-bye.